article published this week in AJR evaluated variation among radiologists and recommendations for additional imaging on head and neck examinations. The authors evaluated reports from 39,200 head and neck CT or MRI exams interpreted by 61 different radiologists. Radiologists' rates of RAI ranged from 0.8% to 22.0%. A generalized mixed effects regression analysis was performed to predict RAI, including a wide range of patient, examination, and radiologist factors. Of explainable RAI, 25.7% was due to fixed factors and 74.3% to individual radiologist-specific behaviors. The authors conclude that most variation is due to radiologist decision-making, or in other words, the opinion of the radiologist. I'm Andy Rosenkrantz, editor-in-chief of AJR, and I'm here today to discuss the article with its first author, Dr. Jeffrey Guenette, assistant professor of radiology at Brigham and Women's Hospital. Dr. Guenette, thanks so much for being with us today.
Hi, Dr. Rosenkrantz. Thank you so much for having me and letting us discuss this article further.
Why is it important to study variation in RAI across radiologists?
So when there's substantial variation among provider practices, patients get unequal care depending on which doctor they see. And patients aren't able to select, in most cases, which radiologist they're going to see. So depending on who happens to read the examination that you had on that given day, you may be more or less likely to get recommendation for additional follow-up. And part of the reason there's so much variation is because we don't know where the baseline of follow-up recommendations should be for most of these diseases or most of these findings due to a lack of evidence. In addition, it also leads to diagnostic error. There's evidence in the cognitive behavioral literature that when you have a lot of noise or this type of variation in any professional setting, you end up with diagnostic error on both sides. So either recommending too much or recommending too little leads to diagnostic error for patients.
Why do you believe that the observed variation in the head and neck was so high?
There are a few possible reasons for this. One of the reasons in our initial hypothesis for this study is that in head neck imaging, there are not many guidelines for incidental findings, and there aren't many guidelines because there's not much evidence published on when to make a recommendation or not. So there are guidelines for incidental thyroid nodules, and there are guidelines for incidental pituitary lesions, but other than that, any recommendation that's made for a head and neck imaging finding, there's no evidence on whether we should recommend or not, because there's no data on what the outcomes are of those recommendations, whether they're followed by the ordering providers, whether they're thought necessary by the ordering providers, whether they're just lost in the shuffle of daily care. So until we know more of that information, it's very hard to know when it is proper to recommend, hence the expected variation.
Can you explain the analytic model further to us?
Sure. So we did a few things in this study. First, in order to test whether the variation between providers was significant, we ran a regression model, a simple regression model without with just fixed effects, without random effects. And then we ran a model with radiologist as a random effect. And then we ran a likelihood ratio comparing those two models. And that provides a measure of significance of whether the influence of the radiologist was significant on the likelihood of a recommendation for additional imaging. And then we also put together a mixed effects model very similar to in that first case, where we included a large range of patient factors, examination factors, and radiologist factors. And this was an exploratory model. We included radiologist as a as a random effect in that model as well. And that gave us an idea of what types of factors are playing a role in whether a recommendation is going to be made in any given type of exam or not. And then subsequently in that, we ran an R-squared calculation on that model to look at how much that model accounted for the the variation, how much that model accounted for the predictability of a recommendation for additional imaging. And that R squared gives us, breaks down into a component that is for the fixed effects, which are the variables that we're studying, the factors we're studying to see if they are meaningfully associated. And then it also has a component that looks at the random effect, which is the radiologist effect, and effectively the behavioral effect, as you were pointing out in the highlights of the study.
You also looked at the association of RAI with a trainee. What did that analysis show?
Yeah, so what we found was that reports with trainees were significantly more likely to contain recommendations for additional imaging than reports without trainees. And we have a couple theories on that, and more study would be needed to definitively ascertain this relationship. But one possibility is that radiologists in training are more inclined to make recommendations due to higher degree of diagnostic uncertainty. And then that ends up reflected in the final radiology report, because once there's bias on the part of the attending radiologist. Now they've been biased to think that maybe they should be recommending this. And so that's one potential option. The other potential component to this that we can think of is that the case mix is probably different for the trainees. So at least at Brigham and Women's, this was a 4-center study, but at least in Brigham and Women's Hospital, we read about half of exams without trainees. And so we try to reserve examinations with higher case complexity or more interesting teaching points for trainees. And there's a good chance that there's selection bias in which examinations were read by trainees.
Separate from the model, you looked at RAI among 4 different radiologist groups, as you were just mentioning. Can you tell us about that part of the study?
Sure. So we wanted to see what interradiologist variation was like across the 4 different sites that we included. So this was a single healthcare system study with effectively 4 different sites. 2 academic medical centers, 1 subspecialty head neck hospital, and a community group of radiologists. And so on the whole, each group had similar degrees of variation within each group. No group had a substantially smaller amount of variation than any other group. One group, which had some prior interventions around recommendations for additional imaging, had an overall lower recommendation for additional imaging rate. However, there was still substantial variation around that lower baseline.
What do you recommend as next steps based on your findings?
So this study was largely confirmatory of our hypothesis that there's a lot of variation. We need to now determine how much of that variation is leading to diagnostic error. That's the ultimate goal here, is to identify where diagnostic error happens and how that's occurring. And so we need some more longitudinal studies to look at whether which is diagnostic error happening on the higher side of recommendation rates due to extra care given, additional interventions that are unnecessary that cause harm, delays in diagnosis when the diagnosis could have been made on the original exam. Those are all forms of diagnostic error. Or is diagnostic error happening on the side of people who are not recommending as much, where we are having more misdiagnosis or misdiagnosis? It's missed diagnosis or misdiagnosis. And we're not sure which of those it is. So each of these typical, or the more common recommendations we are looking into at this point, and we encourage others to look into it as well, to see how often are those recommendations being followed, and then what is the impact on care on those recommendations. Once we have evidence about the impact on care of these different recommendations and the epidemiology, tie that into the epidemiology of the underlying diseases, like has been done with thyroid nodules, then we could come up with guidelines. And when people follow guidelines, ideally they'll follow the guidelines, but when they follow the guidelines, that should shrink the variation around a very expected baseline where we know what our ROC curve is going to show for accuracy in diagnosis and diagnostic error as the trade-off compared with prompt diagnosis.
Dr. Guenette, thanks for joining us to discuss your article.
Thank you, Dr. Rosenkrantz. It was a pleasure to be here.